Hi, I am Ameer Hassan. I'll be talking about artificial intelligence in stroke and where are we going. Here are my disclosures. So what is artificial intelligence? And the thing is, it's really more computer-aided triage. So artificial intelligence is computer-powered algorithms designed to really assist all of you, right? The healthcare professionals in the detection of something. So in our case, it's going to be about detection of a large vessel occlusion, aneurysms, intracerebral hemorrhage, and what to do with that. What to do with that information. Triage, management of that medical condition, and especially in acute ischemic stroke, intracerebral hemorrhage, these things are critical, life-threatening, so we want to do it as fast as possible. Like we always say, right? Time is brain. So a little bit about our program. We do about 1,300 neuro cases a year, 50-50 intervention diagnostic. We did about 250 mechanical thrombectomies in 2020. We are currently 3 neurointerventionalists, all neurology background, all critical care background. Valley Baptist has 566 beds. It was the first comprehensive stroke center in an catchment area of 1.5 million. And I'll show you in a little bit the map of our area. We were enrolled in, we were part of and enrolled in Swift Prime, Dawn, Select. We're part of Select 2. You know, every major stroke trial that comes out these days, we try to be a part of. So here's the southern tip of Texas. So let's see here. Can you see my laser? There you go. So you see the pointer? So San Antonio is about 4 hours away. Austin is another hour north. Houston is 5 hours away. And we are here, this purple dot on the bottom, Harlingen. And South Padre Island, for those of you who remember your spring break days, South Padre Island is about 40 minutes away from our hospital to the east, and McAllen is about 45 minutes to the west. But we do have sites that transfer to us from Corpus Christi, which is a 2.5-hour drive. So everything from Corpus Christi down to Laredo basically comes down to the southern tip of Texas, northern Mexico. So the average transferring hospital's distance is 57 miles. So one of the main problems with mechanical thrombectomy utilization, and for those of you who don't know, NT 2020 is our Big SVIN initiative. We're doing a dinner tomorrow if you guys want to come and join. It really is about improving mechanical thrombectomy access worldwide. And just looking at the United States, right? NT 2020's vision is really to improve mechanical thrombectomy worldwide, but even in the US, you have a significant difference in different metropolitan areas. So for example, in Denver, Don Fry and Company, 9.3% of their strokes are treated with mechanical thrombectomy. Very good utilization rates. Now look at Buffalo, Adnan Siddiqui, Elad Levy, 8.1% utilization of mechanical thrombectomy. Now look at the other spectrum. San Antonio, Washington, DC, 2%. So we have a lot of work still to do here in the US. But the idea is we should be treating 10, 15, some people even say up to 20% of our strokes with mechanical thrombectomy, especially if Mayank gets his wish and we start treating all distal vessels, DIVOs and MIVOs. So we do have a lot of work even here in the US. Now we know there are long treatment times for transfer patients. And one of the reasons, and we'll discuss specifically our hub and spoke and the times that we had and the times we had after implementing VIS. But this paper was written by Mike Froehler, part of the Stratus Registry, published in Circulation. And direct patients from onset to treatment was on average 3.8 hours. If you transferred, it was about 5.2 hours. And we know that there's a $1,000 benefit in thrombectomy for every minute you save. Now, flip the page. On the other end of the spectrum, hospitals full, COVID going on. I had 70 patients waiting in the ED before I flew out yesterday. 7-0. Hospitals full, COVID everywhere, and of course other diseases. So I don't want to accept a futile transfer. I want to do a better job screening which patients should come to my facility. Of course, as Dawn and Diffuse 3 were published, increased volume, right? So we're getting more calls, more screening. So I want a good tool that's going to make my job as an interventionalist, as a stroke neurologist, much easier. And then, of course, lack of ICU beds. We have a 14-bed neuro ICU expansion that should hopefully open March 1st. It was supposed to open a year and a half ago, so I'm not holding my breath. Provider burnout, right? We all get too many alerts, too many phone calls from the ED. We're glued to the hospital, we're overextended. So having a tool that's going to help me deal with that is really very important. You all know this graph, you've seen it at ISC since 2006, since Pooja showed it. 2 million neurons are lost every minute you delay stroke treatment. What does that mean? So if I can decrease treatment time by 20 minutes, you gain 3 months of disability-free life. So how do we do that? So we know the old trials were significantly delayed. There were a lot of issues. Everything went very slow, and that's why none of those trials were significantly positive, right? You had poor patient selection protocol, limited vessel imaging, limited use of current new generation devices. I think 28 out of the 500 patients combined were treated with a stent retriever, which is standard of care today. If anybody's still using Mercy, please call me. That physician should stop. And slow times. Think about this number. So for those of you who haven't listened so far, 124 minutes from imaging to puncture was the average in those studies. Today, we are expected to have a door-to-device time of 90 minutes. If this happens today, heads are rolling. Like seriously, I think my ED physician would be more pissed off than I would be. So this is unacceptable in today's world. So obviously the big thing was everything was going very slow. And my clicker, there we go. Everything was going very slow. For those of you who don't know, I'm a huge car fanatic, and Yugos are very slow cars. Anyways, so we were also average gunslingers. This is us at University of Minnesota. I see some of my friends here who I know from Minnesota in the background. This was the first solitaire case performed at Hennepin County Medical Center. This was a couple of months before I graduated. And Dr. Gregorian was my co-fellow. Dr. Techley on the bottom there is my partner today. And this was all of us super excited. This is the first time solitaire is being used. First time stent retriever FDA approved, and we're all excited. And we had no idea. Should we hold it up for 5 minutes? Should we deploy it and just pull it out? Should we aspirate first? Do we use a balloon guide? There were so many unknowns in the beginning. So obviously, we all got better, and recanalization rates got better with experience. So how do we treat more patients faster and better? Technology is obviously the answer. Having an artificial intelligence powered alert, having a mobile image viewer on your phone, right? Not having to open email or go to a desktop. Real-time patient updated information. If we know last known well, NIH stroke scale, any of that information gets changed, we can quickly put it in the app and everybody gets alerted. HIPAA compliant communication, which I think is actually, for us, that was the first thing that sold our team. We're a research site. I have 14 active studies, probably 16, 17 in the pipeline. We're part of all the new devices that come out. And it is a great tool for your patients coming from your spokes to quickly communicate together. What's going on? What's the NIH? Is this patient potential study patient? Large core, new devices. You're offering a procedure that would not be offered for this procedure otherwise, right? Prior to dawn, we were not treating late window. I mean, some of us were. We believed in it, but some of us weren't because there was no data. There was no guidelines to say that it was safe to do. Same thing with large core today. So I think the HIPAA compliant communication tool was by far, it opened up a lot of doors between us and our spokes. It closes the loop. If I'm in a case, they see the large vessel occlusion, they're messaging, hey, we're transferring this patient. They just make everything, everybody feels like they're part of one team. And then once we're done with the procedure, we take pictures, we send it, and everybody's happy. They know what happened to the patient, and they know what happened to the transfer. Sorry about that. So again, the key here is AI is designed to assist the healthcare professional in the automatic detection. So early on, we did this project called Steps T, and the idea was how could we get these patients treated faster? And we focused on stroke triage education, procedure standardization, and technology. We called it Steps T, and it was published. And the idea was working on a standardized workflow, making everything simple for the techs, the nurses, so they know, hey, if I have a stroke, you should only ask me one question. Do I want a Simmons in that guide catheter, or do I want a Vert catheter? It's everything prepped, ready to go. Microwire, microcatheter, aspiration catheter, everything's set up. Everybody knows what they're doing. Nurses know, techs know, monitor knows. This was published in Interventional Neuroradiology back in 2017. So we showed that it improved time to treatment of patients undergoing mechanical thrombectomy. But here's the problem. That is the smaller part of the window. So when the patient arrives at hospital door to recanalization, the interventional time is a much smaller portion of the total time. So that's when we said, okay, we need to focus on door to intervention. And it was perfect timing, right? To say the stars aligned. So there was a tool for early detection, rapid triage, and synchronized care. And that's what Viz offered. So I'm not going to get into this algorithm here, but I'm going to basically kind of show you what it does. So the idea is you have a series identification based on metadata. And you get this CT angiogram. And what does it do? It takes the image, and then it's extracting information from it. It's removing, right, head mask extraction. It's looking at vessels. It's doing centerline growing, image analysis, registration, and here, segmentation of large vessels. And then, see that? So it can tell that there's something wrong. So what happened? Oh, that line doesn't continue. There's probably a large vessel occlusion. And that is basically, obviously a dumbed down version of the science behind, anybody can do this in their backyard, the Viz algorithm flow. So there's supposed to be some pictures there. And basically the idea is it uses the information from the CTP. It uses the large vessel occlusion detection, and it pushes it to your phone. If you have an Apple Watch, it pushes it to your watch. And you can see the colors. So my kids always have a lot of fun with this, with the CTP. They're like, Dad, green is go, red is dead, right? I go, exactly. So they know if they get to keep my phone to play their game, or I have to go to the hospital and treat a stroke. There we go. So here's the center line measurements. So it obviously picks up cases like ICA occlusion, right? The initial indication is only for MCA, but because of those cases, the thousands of cases that have been put into this, now it picks up ICAs, it picks up M2s. The software is smarter and continues to get smarter. Here's some other examples, but I want to get to our data. So the key here is going from a serial to parallel delivery, right? And the perfect example of this is at our site. So first I'll let you watch this video. So this is an example of a patient who gets a CAT scan. The technologist, CT tech, has to post-process that CTA. Then radiology reads it. Radiology calls ED. ED calls neurology. Neurology calls interventional. This is the process at most of our primary stroke centers, part of our hub and spoke network, and that is what they did prior to Viz. So the average was 123 minutes. Now, hopefully the next video kicks in. The idea now is after the CTA, those images are pushed to the cloud. I don't have to wait for the radiology tech to post-process those images. So I'm getting that push in 6 minutes, whether or not there's a large vessel occlusion, and I can look at the CTA myself and decide if there really isn't or there was. And synchronized stroke care, 39 minutes. So everybody's like, oh, this is a cool video, Ameer. Does it really happen in the real world? Okay, that's a great question. So first we'll talk about this. So they're best-in-class machine learning. 96% sensitivity. This is published, right, with Viz AI for large vessel occlusion detection of MCAs. 96% sensitivity, 94% specificity. Now, here's our data. So this was presented a couple years ago at ISC. I think it was the same year, 20. So ISC 2020, the last time we all got together, and it was published the same year in Interventional Neuroradiology. And basically, we wanted to look at pre and post Viz at a hub and spoke model. What happens? So Valley Baptist Brownsville is a primary stroke center with amazing neurohospitalists, great stroke coordinator, well-oiled machine. These guys give TPA in like door to needle 15, 20 minutes. Their average is under 30 minutes. So it's a well-oiled machine. It's not like we took a program that was questioning whether or not to give TPA and then we introduced them. No, this is a well-oiled machine. And then look at the number of steps on the bottom here. The number of steps that it takes to trigger a transfer. And then look at what happened with Viz. We saved over an hour. 66 minutes from primary stroke center picture to comprehensive stroke center door was saved. Now, and that includes ambulance, which I wish I could fix, and I'm still trying to fix, but they have a problem transporting patients with TPA in Brownsville. And it's run by the local fire department, and I can't get a competitor to take over. So we found another solution, tenecteplase. Bolus and run. So, but that's not part of this conversation. So the best thing we did was speed things up. Getting that image pushed to the interventionalist's phone, the stroke director's phone, the stroke coordinator's phone, everybody's on the same page. Everybody hustled to get that patient moved out. There's not this phone game going on calling house supervisor, hospitalist, interventionalist. So that was a previous C7, and this is the new C8. And I got to give General Motors a lot of credit, because this car is 0 to 60 under 3 seconds, and it only costs $65,000. So I just wanted to put that plug in. I'm sorry, the clicker is really delayed here. Okay, so 39% reduction in time from primary stroke center to comprehensive stroke center. And that directly correlated to a 55% reduction in neuro-ICU length of stay. So what does it mean? Well, obviously, if my patients get here sooner, they have better outcomes, right? First pass success, recanalization, you save neurons, and they don't need to stay in the neuro-ICU as long, right? Less hemorrhagic conversion, less bad outcomes. So we found a 55% reduction in neuro-ICU length of stay, and I believe we ended up saving 3.5 days in the neuro-ICU and 2.5 days total stroke admission. So this makes a big difference, because everybody always asks, well, why should I pay for this? Well, that's the reason, right? I know the CFO doesn't care about my patient. He really doesn't. He cares about dollars. His job is to worry about the hospital and how much money the hospital makes and spends, and he has to cut the check. But when I show him that, listen, time is money, not just brain, maybe I might get the message across to him with this slide, right? Now, in the end of the day, does he really care about some hypothetical number that came out of some study? Maybe not. But when you look at this, $70,000, this is the cost effectiveness of the time saved with mechanical thrombectomy. But that wasn't enough. It really wasn't. So we did this. Overall length of stay, average 2.5 day reduction. That is $12,000 per admission for every patient transferred from Valley Baptist Brownsville. And that got his ears perked. Right? He got excited. And now he's like, okay, can we put this in all the hospitals now? And now, of course, we're fighting with other institutions to bring on primary stroke centers. So that data was published showing our time saved, 66 minutes saved. Joanna Fifi and Jay Mako showed their Mount Sinai data showing significantly improved clinical outcomes. The mean 5-day NI scale, as well as discharge modified Rankin. And then, of course, Don Fry and company showed that 44% more mechanical thrombectomy procedures were done. So for those of you who have an up-and-coming stroke program, you want to increase your volume? This is one way to do it, right? You're going to find more M2s, M3s. And as the evidence grows, we are going to be treating these patients. I don't know about you, but I don't leave most of these patients if they have an NI stroke scale 6 or greater. I will treat them. I don't care where the branch is, as long as I can get there safely. So this is the slide I asked to be added because I really liked it. This shows, on average, the minutes saved all across the country. And it really shows you that it is a big deal, right? In South Texas, our catchment area is about 1.5 million people, but Harlingen's a city of only 60,000 people. That's it, 60,000. So for us, it makes a bigger difference because Brownsville is about 30 miles away. Whereas in New York, I mean, you can throw stones between all the different CSCs. The problem is probably traffic. They still save 33 minutes in a well-oiled machine in a large hub and spoke CSC. 69 minutes saved in Atlanta, 20 minutes in Carolina, 44 in Memphis, 41 in San Diego. So it's not just a single center experience. This really is, savings across the United States. So last year at ISC, we presented this data showing the door in, door out times, and it's currently, we just responded to the reviewers' comments. So we wanted to see, okay, are we also improving just the door in, door out, right? Maybe that 66 minutes saved was, EMS magically got better overnight. So no, let's look at just door in, door out at the primary stroke center. And what did we find? So again, Brownsville's 23 miles away. It's about a 30-minute drive. This thing's really delayed today. Okay, so 45% reduction in door in, door out time. So it wasn't EMS. Actually, EMS was probably the status quo. It's 102 minutes saved. Now, obviously, we expanded the window now, right? So we've had Viz now there for 2.5 years. We just didn't look at 1 year worth of data. And then we looked at 2.5 years pre-Viz. But 102 minutes saved from a primary stroke center, well-oiled machine. And then that led to an 11% improvement in good modified Rankin 0 to 2. So the incorporation of the Viz software definitely improves door in, door out times at your primary stroke centers. So then we looked at, okay, mothership. How are we doing with mothership? Do we improve time? Do we have any benefit, or is it just at the spokes? Because I used to get asked this question a lot by a lot of my colleagues in the field. Hey, Ameer, I saw your abstract at ISC. Does it really make a difference, or should I just put in my spokes? And hopefully this will click. So we looked specifically at November 2018 to May 2020, and then we went back to November 2016 for the pre-Viz period, and we found, oh wow, okay. I jumped a few slides. That really jumped a lot of slides. Okay. Not sure what happened. But we found basically, again, significant reduction in the length of stay at the comprehensive stroke center. Improved outcomes, decreased length of stay, and there's no cost to you, right? If it's an issue of software, I mean, we spent $7,000 for a stent retriever. Does it really matter when you're treating 250 mechanical thrombectomies a year? No, but you are getting much better outcomes. So this is extremely important. So again, decreased length of stay, proven impact across the continuum of care, about 102 minutes for door in, door out on average for your referral centers, 52 minutes faster than the standard of care, and then 86 minutes saved when looking at door into groin puncture. Looking at all this multi-center data, again, saving time, improving outcomes, increasing access to care. So if I have a minute, just want to talk about a Viz ANX, which is a new comprehensive AI-powered solution for detection and triage of unruptured aneurysms. So the problem is today we have manual identification, right? You have inconsistent diagnosis, inconsistent care pathways, patients getting lost, even if they do find something. So what about if you were able to do referrals through your app after an aneurysm was detected on a CTA? And this is what Viz ANX is offering. AI-powered detection of a suspected aneurysm, capturing that suspected aneurysm patient, and then referring to clinic for follow-up. So we're not saying we're going to treat all these aneurysms, but at least follow them. Make sure there's no change. If this patient develops Mickey Mouse ears in 2 years, that probably needs to be treated, even if it's not 7 millimeters, right? So we can start going through risk stratification. I'm going to treat a 4 millimeter cavernous different than a 4 millimeter pericallosal, like one of my friends just said, 30 minutes ago before this talk. It is extremely important for risk stratification. You can't just have this blanket statement, 7 millimeters or more I'm going to treat. It really depends on where it is, what it looks like, the morphology. And I do think tools like Viz ANX are going to improve patient care and at least make sure that we don't lose these patients. So we hope to detect more aneurysms, ensure follow-up, and improve outcomes for these patients. And there is Viz for the Embolize trial. We are part of the middle meningeal artery embolization trial, Medtronic, it's called Embolize, detecting subdurals for potential enrollment in the trial, and it's randomized to medical management versus MMA embolization. So we did enroll 2 patients last month. I think for once my name was higher up than Max Mokin, but he's the heavy hitter in that trial. And thank you very much. I hope to see you all at SVIN. Next year it's going to be, or this year, November, it's going to be in Los Angeles, November 16 and 19.